Hello, and thank you for clicking on this video. This is a Grand Rounds lecture that I recently gave and decided I might as well just throw it up on YouTube in case anybody else could benefit from it. It's titled Prostate Cancer Screening: How Our Clinical Practice Diverges from the Evidence. This lecture is meant for a general audience of healthcare professionals and pre-professional students, and is generally not targeted towards patient education and should not be considered personalized medical advice or a substitute for personalized medical information from your provider. So the agenda is we're going to start with the evidence of possible mortality benefit with screening PSA, risks of overdiagnosis, downstream complications of PSA, PSA guidelines, screening digital rectal exam, and how common practices differ from the guidelines. And this is the reason I decided to give this lecture, is because, at least in primary care, this is the number one thing I see where what most people are doing differs pretty significantly from the actual guidelines and evidence. We'll start with the mortality benefit, or lack thereof. There have been 5 randomized controlled trials on PSA screenings. This is the bias table from the Cochrane meta-analysis, and for the sake of time, we won't dive too much into this, but it's pretty self-explanatory, where the green pluses means there's low risk for bias, and the red minuses mean there's high risk for bias. 3 of the 5 studies are small, relatively low-quality randomized control trials that did not find a statistically significant mortality benefit. But because they're smaller and lower quality, we probably don't put as much emphasis on these results. So that leaves us with 2 larger studies with low risk of bias. One in the US, the PLCO study, and one large European study, the ERSCP. But unfortunately, these 2 large low-risk studies have conflicting results, which makes it a little bit murkier as far as what the final conclusion is. The American study, the PLCO, had 77,000 men randomized to usual care versus annual PSA screening for 6 years, with 10 years of total follow-up. There was no statistically significant prostate cancer specific mortality benefit in this study. The major criticism of this study is the contamination rate. So the PSA usage in the control arm that was randomized to usual care had up to 52% PSA usage in individual years, and over the course of the entire study period, as many as 85% of the participants had at least one PSA, which very much muddies the waters if we're trying to figure out what the benefits possibly are of PSA screening if the control arm that was randomized to no PSA ended up getting PSAs outside of the study. That makes it harder to differentiate the true effects of PSA. But I will point out that contamination is a real-world phenomenon as well, so it doesn't necessarily negate these results completely. When I decide whether or not to do PSA screening for a patient, I'm not deciding whether or not they will or will not ever get a PSA. I'm just deciding whether or not they will get a formalized, routine, regular screen from me. But they may have recently had a PSA from their prior doctor before switching to me. They might switch doctors when they move or change insurance in a few years and get a PSA from that doctor. They might see a subspecialist. They might develop a symptom like a UTI that leads to PSA screening. So it's not crazy to think that this is a real-world situation that means this study actually does represent real-world results. There was a study where they tried to separately reanalyze the PLCO data based on what the patients actually had done as far as PSA versus no PSA. And they tried to essentially unrandomize the results. It did show that there was a mortality benefit to PSA screening when they did that, but these reanalyses, statistically looking back at studies, certainly have a higher risk for confounding because you're removing the randomized element and doing some guesstimation with statistics after the fact. The second of the large low-risk studies is the ERSPC study. This had 162,000 European men randomized to PSA or usual care with 9 years of follow-up, and participants received between 2 and 8 PSA tests during the study. It's usually cited as a single study, but really it was 9 slightly different studies with different ages included, different screening frequencies, and thresholds for biopsy. The results from a single site of the 7 in Sweden ended up showing way more benefit than the other 6 sites. I believe this is pronounced Göteborg, Sweden, is where the one site that had outlier results. The results from Göteborg were also kind of added to the study after the fact. So this Swedish site was actually a study that was already underway before the larger ERSPC study was formed, and it just got kind of absorbed, which is a little bit atypical and suspect because they were already enrolling patients and getting some preliminary results before they got added onto this as yet form study, which is potentially means it's not an apples to apples comparison. And the fact that this one site that was added in a somewhat atypical fashion also was the one that showed way more benefit than the other sites further leads to some questioning of what this could really mean. So when looking at the study overall, there was a statistically significant decrease in prostate cancer mortality for PSA screening in men between the ages of 55 and 69, with a 20% relative risk reduction, but only an absolute risk reduction of about 0.7 deaths per 1,000 participants. Therefore, the number needed to screen is about 1,400 to prevent one prostate cancer death. The paper only very briefly mentions that the headline results are only for a subgroup of data. When all the data is included with all of the participants that were enrolled from ages 50 to 74, there was actually no mortality benefit that was statistically significant. If you just read the paper and the abstract, it makes it sound like the whole study was a positive result, but really they wrote the whole paper based on a subgroup analysis, which is also kind of suspect. You have to look pretty closely at the tables to realize that they had to exclude chunks of their patient population to get a statistically significant result. I already mentioned how the Göteborg, Sweden site, the one of 7 locations involved in the study, also had significant outlier results, and it was such an outlier that it actually changes the results to being statistically significant. If you look at the data from just the other 6 sites in the study and remove the Swedish arm, it's actually not a statistically significant result anymore. So to summarize, we have 5 randomized controlled trials. 4 of them do not show statistically significant prostate cancer mortality benefit. With 1 of them, the ERSCP, does show prostate cancer specific mortality benefit. But with some caveats, only if you look at a subgroup of 55 to 69 in that study. If you include all participants, including 50 to 75, then the study becomes not statistically significant. And if you look at just the 6 other studies other than the Swedish arm of the ERSCP, even if you look at the age subgroup 55 to 69, the statistical significant benefit goes away. So you really have to put a lot of weight on the Göteborg Swedish single site in one study in order to justify PSA screening, because there's consensus among all the other randomized control trial data for PSAs that there's no mortality benefit. There was also a Cochrane meta-analysis, including data from all 5 studies, that also showed no statistically significant prostate cancer mortality benefit. The number needed to screen depends on which of the data we're looking at, but even the best case scenario, if you're just pulling out the ERSCP data, it's 1,400 needed to screen to prevent 1 death. But if we look at the other data, it could be as high as infinity as the number needed to screen to prevent 1 death, because it's unclear if PSA screening does prevent any prostate cancer deaths. I will point out that since most of us only have a portion of our patient population that is both male and within the age groups that we're talking about here, 55 to 69, and this number needed to screen includes 10 plus years of screening, that means that a number to screen of 1,400 could be a full career's worth of a primary care physician, for example, doing routine PSA screening. Meaning this is on the scale of a number needed to screen where you could routinely screen all your patients with PSA and potentially not prevent a prostate cancer death over your entire career. Based on the randomized control trial data we have, the number needed to screen could be infinity for patients over the age of 69. Really, when we debate whether or not there is mortality benefit or not, we're just talking about that 55 to 69 age group, because even among the ERSCP study, 70 plus does not have prostate cancer specific mortality benefit. To give you a comparison of some of the other cancer screenings that we do, here's the number needed to screen to prevent 1 cancer death with some other common cancer screenings. So for mammogram, it's 233 over 9 years. Screening lung CT is 320 over 6 years in smokers and former smokers. Fecal occult blood is 377 over 18 years. Pap smears is 1,100 over 10 years. And PSA is, like we said, somewhere between 1,400 and infinity over 9 years. I should add that the original studies that we've been talking about have been updated with some longer term data, but it doesn't really clarify things because the 2 main studies came to the same conclusions, so it's still unclear. The PLCO study with 15 years of follow-up still had no statistically significant mortality benefit. They also went up to 23 years of follow-up in the ERSCP study. The effects were still statistically significant, but with a smaller effect size of 0.13 instead of 0.2 relative risk reduction. This time they did not give the results with the Swedish data removed, so it's hard to know if the other 6 sites really agree with the Göteborg Swedish data this time around. The results were still only statistically significant for that subgroup of 55 to 69. The number needed to screen to prevent 1 death was 456, which sounds a lot better than 1,400, but number needed to screen is a time-dependent thing. So if you try to compare this number to the other cancer screenings that I mentioned, it's not an apples to apples comparison anymore. Most of the other cancer screening numbers I mentioned included screening over about 10 years. So now that we've got data going to 23 years, it makes this number sound a lot better than it really is. This long-term ERSCP study also essentially republished what the results from the first 9 years of the original study should have been. As you can expect, the original study, they had some gaps in their data and whatnot and had to make some guesstimations. But now that they had some more complete data decades later, they republished what the results would have been at that 9-year mark, and the number needed to screen instead of 1,400 was 1,900, and the mortality benefit was no longer statistically significant. So even the authors of the studies are basically saying at 9 years there was no mortality benefit. I've seen people try to point to this study as some sort of smoking gun to show that PSA is definitely warranted, but if you read past the abstract, it really doesn't say that. If you actually read the results and look at the tables and realize the effect size is smaller and it's still just a subgroup analysis, and the 9-year data actually wasn't statistically significant, I wouldn't say this really strengthens the PSA argument. This is the most damning piece of evidence, in my opinion. So the blue line here is the rate of, or the incidence of prostate cancer diagnoses. And you can see after the FDA approves PSA for screening, the number of prostate cancer diagnoses skyrockets. And then around 2012, when the United States Preventive Service Task Force started discouraging PSA and we started doing a lot less PSAs, then the number of prostate cancer diagnoses dropped significantly. So there's a clear correlation between PSA usage and the diagnosis of prostate cancer. But what you see at the bottom here, this red line, is actually prostate cancer mortality. And despite pretty dramatic swings in PSA screening up and down, you can see that the mortality data essentially does not change at all, which would pretty strongly suggest that the use of PSA does not have clear mortality benefit on a population scale. The entire idea underlying screening is that identifying a cancer sooner will change the outcome, and for prostate cancer that's not necessarily true. The PIVOT trial was a randomized control trial comparing early surgical treatment for localized prostate cancer versus active surveillance, and they found that surgery did not decrease prostate cancer specific mortality, even with 20 years of follow-up. Another randomized controlled trial comparing radiation to prostatectomy and active surveillance for localized prostate cancer with 15 years of follow-ups showed there was no statistically significant difference between the three groups. So if more aggressively treating cancers earlier on does not affect mortality, that would explain part of the reason why PSA screening does not have mortality benefit either, because even if we identify it a little bit sooner, it's probably not going to change things. Thus far, I've just been talking about prostate cancer specific mortality, because I didn't want to flip-flop back and forth and confuse people. But now I will point out that all of the studies are in consensus that there is no all-cause mortality for PSA screening. So even the one study that showed a reduction in prostate cancer-related deaths, the patients do not live any longer based on getting a PSA. For comparison purposes, though, I will point out that the other cancer screenings we do routinely also do not have all-cause mortality benefit, so this does not necessarily mean that PSA is completely off the board just based on this. Sometimes when the mortality benefit is presented and not very favorable, people will want to point to metastatic data instead and say that that's justification for using PSA screening. But I'll say there too, the benefits are uncertain and small at best. The PLCO study did not show a statistically significant decrease in metastatic cancers. So the difference between the screening and non-screening group was 3.6 versus 3.3 per 1,000. Not all of the ERSCP study sites tracked metastases, but of the few that did, they had a statistically significant decrease in metastatic cancers, but the absolute reduction was only 3 per 1,000 men screened. Here's some other more population-wide data looking at metastases. So you can see that the rates of T3, T4 locally metastatic spreading cancers does increase after 2012. That's the point where we stopped doing as many PSAs because the United States Preventive Service Task Force started actively discouraging it. But even though the graph is heading up to the right, which would generally be a bad thing for cancers, you have to keep in mind this is a relative change and not an absolute change. Even though the graph is trending upwards, this is data for new diagnoses per 100,000 men. So the difference from 2012 to 2018 is a difference between 0.05% of men getting a metastatic cancer diagnosis and 0.035% of men getting a metastatic prostate cancer diagnosis that year. So the absolute effect is very small, even though the relative effect looks bad in the graph. Here we have the rates of M1 distant metastatic cancer. This is a little bit more pronounced as far as the incidence. But here too, there's a big difference between the two age groups. So under age 75, the line only very slightly goes up. For men above the age of 75, the rates of distant metastases does go up more significantly, at least on a relative basis. But there too, the absolute change over this time period is relatively small. So a difference between 0.06% of men getting diagnosed with distant metastatic prostate cancer when we were doing more PSAs compared to 0.09% when we were doing less PSAs based on the guidelines in that period. Now we'll talk about overdiagnosis. Overdiagnosis is the detection of medical conditions that would never have caused symptoms or death during a patient's lifetime. Screening PSA largely detects indolent cancers that would never cause morbidity or mortality. These men end up labeled with cancer despite no clinical benefit. In medicine, we tend to act as if there's a clear line between cancer or not. And when we're talking about cancer based on histology, yes, there is a clear yes-no answer. But when it comes to something like prostate cancer, the presence of a histologic cancer does not necessarily equal a clinical cancer. The United States Preventive Service Task Force estimates that about 50% of cancers diagnosed through PSA screening are overdiagnosis. In a meta-analysis, rates of incidental prostate cancer on autopsy is about 60% in men in their 80s. To clarify, this is men that died with prostate cancer, not from prostate cancer. So we just took a group of men over a series of studies who died from something else, and we happened to do prostate biopsies or examinations on autopsies, and most of them have prostate cancer. So you can easily see how it might not make sense to screen for a condition that's almost inevitable at a certain age group. Now we'll talk about the downstream complications of PSA testing. One of the reasons that PSA testing is used so heavily is because if you're looking just at the short term, there doesn't really seem to be a downside. The patient's probably already going to the lab, so what's the harm in adding a test that's probably free to them onto the lab slip? It doesn't seem like a big deal. But the problem is that there are downstream biopsies and procedures that do have complications that directly result from that initial PSA order. Once the ball gets rolling with a positive result, it's a lot harder to stop the process. Whereas if you're trying to avoid some of these drawbacks, it is a lot more effective if you just don't order that initial test if it's not warranted. Meta-analyses estimate that for every 1,000 men screened with PSAs, prostate biopsies result in 94 more men with blood in their semen, 67 more men with blood in their urine, 45 more men with pain, 19 more men with fever, and 1 more man hospitalized within 35 days of the biopsy. I will point out that a lot of these side effects are short-lived after the biopsy, but not necessarily. And 31% of men who get a normal biopsy result will undergo a repeat biopsy within 19 months. So this is not a one-time thing. Even if it's a normal result, you will likely, a chunk of them at least, will get another biopsy later because there are false negatives, and we're always concerned we just missed the cancer with the biopsy. The effects of prostate cancer treatment are more significant and longer lasting. The United States Preventive Service Task Force estimates that for every 1,000 men screened with PSA over 10 years, that the resulting prostate cancer treatment causes 54 more men to have erectile dysfunction and 15 more men to have urinary incontinence. So it depends on which of the data sets we use, but even using some of the more favorable data, if we kind of cherry pick out the ERSCP data, we're still having more than 50 harms for every 1 prevented death. And with regard to incontinence and erectile dysfunction, we're generally talking about permanent complications for the patient. The maker of Depends are one of the main funders of some of the advertising campaigns that encourage PSA screening and encourage prostate cancer awareness. So I'll leave that up to you to decide if the maker of adult diapers really just cares a lot about men's health, or are they encouraging PSAs because they know a chunk of those men are going to be stuck in diapers for the rest of their life. 8.5% of men end up being admitted to the hospital within a month of getting a prostatectomy. And being given prostate cancer as a diagnosis can increase anxiety and have results from that. So we have another study from Sweden. I don't know why most of the prostate studies are from Sweden, but it seems to always be the case. They had data from 4 million men showing a statistically significant increase in suicide and cardiovascular events in the first year after prostate cancer diagnosis. So this benefit, or this risk, could easily offset any small benefits possibly seen in some of the other data. I will give some caveats and updates on this data that the data regarding harms from PSA is a little bit older, and in recent years the workup and treatment of prostate cancer has gotten less aggressive over time. So the data I just read to you could overestimate some of the harms in modern prostate cancer workup and treatment. MRI is becoming a bigger part of the workup, which can help us prevent jumping straight to surgery even if the PSA is positive. MRI is also being used to help us be more selective with our biopsies. So after getting an MRI, you may be able to just do 3 biopsy sites instead of indiscriminately biopsying like 15 different sites. So that lowers the risk there. Radiation and surgical techniques have also progressed. And the biggest thing is this active surveillance. So once upon a time, if you had a PSA above 4, that pretty much automatically meant you were going to go get a biopsy. Whereas now we track men over time with repeat PSAs and are more selective with how aggressive we are. But while these recent trends may lower some of the harms, it really shouldn't affect the benefits at all. If anything, being less aggressive would be expected to lessen any possible prostate cancer specific mortality benefit. I'll also briefly touch on false negatives. There are a variety of types of prostate cancer that don't clearly raise the PSA. Some of the highest grade, most poorly differentiated prostate cancer cells don't secrete PSA, which makes sense if you think about it. If that prostate cell has changed so dramatically based on the cancer that it doesn't really look like a prostate cell anymore, it's not going to create PSA. If you have a high-grade prostate tumor, but it's small in size, that may not raise the PSA enough to be easily detected. Ductal and neuroendocrine or small cell prostate cancers may not raise the PSA, and the location within the prostate where the cancer is may limit the effects on the PSA. What PSA detects well is low-grade peripheral PSA-secreting adenocarcinomas. And this is one of the reasons that PSA screening overdetects indolent disease while missing some lethal cancers. Only 20% of the prostate cancers found on an end-of-study biopsy had resulted in a PSA during the prior 7 years of screening in the PCPT study. And in another study of 7,000 men, PSA failed to detect 82% of tumors in men under the age of 60. So we're missing a lot of cancers even if we do the PSA screening. Again, I'll compare PSA to some other commonly done cancer screenings for the negative predictive value this time. And you can see most of the other cancer screenings we do have a negative predictive value of roughly 99%. So they're pretty good at ruling things out. Whereas the PSA negative predictive value with a cutoff of 4 is only 85%. So even if you get a normal result, there's still a good chance that you could actually have prostate cancer. Next, we'll dive into the guidelines. We'll start with the United States Preventive Service Task Force. They are kind of the gold standard when it comes to cancer screening guidelines. And in the US, they are who dictates what tests the insurance companies have to cover. In 2012, they gave PSA screening a category D, which means they actively discouraged it, as there was clear evidence that harms outweigh the benefits. In 2018, they changed their recommendation to a category C, which means there's moderate quality evidence that the benefits are at best small, and that the test should only selectively be offered to patients after shared decision making. They ended up keeping the category D rating for patients 70 plus. This change from a D to a C was controversial because there was no new randomized control trial data released in between 2012 and 2018. So they were not having any hard data to justify this change. I will say, as of this writing, the United States Preventive Service Task Force is undergoing their multi-year process to update their PSA guideline. So we will see what the new 2026 or maybe 2027 guideline from the USPSTF is. Here's a table I made including guidelines from pretty much every prostate guideline across the world that I could find. So this has US and international guidelines listed. And we've got 3 columns here, which basically breaks down into a yes, maybe, and no grouping. So we have routine PSA is recommended. PSA is recommended only with shared decision making if the patient decides to do it, or the PSA is actively discouraged. And the first thing you'll notice with this table is that there are no check marks in the yes grouping. None of the guidelines recommend just routinely doing PSA. If I made this table for any of the other cancer screenings like colorectal or breast cancer screening, all the guidelines would be in the routinely recommended yes category. The different guidelines might differ based on their age and frequency of those other screenings, but there's consensus among all the guidelines that it should be recommended to all patients. Whereas with the PSA, that's not the case. There's no guidelines that just recommend doing it. What we're left with is about half the guidelines are in the maybe category, and half the guidelines are in the no category. From my perspective, if half the guidelines say maybe and half the guidelines say no, the average of that is probably just leaning towards no, especially in the setting of us trying to do no harm. That is the one part of the Hippocratic Oath that everybody remembers. So if there's a lack of clarity, it would seem that leaning towards not doing it would probably be the wiser thing. There's also significant limitations to the shared decision-making process. Many patients default to thinking that more medicine is better medicine. So discussing the PSA is akin to just ordering it in many cases. This study showed that discussing the advantages of PSAs with a clinician increases the odds that patients get the PSA screening by a factor of 9. Whereas discussing the disadvantages with their clinician had no association with a drop in screening. Having meaningful shared decision making is also very time consuming and detracts from other tests or treatments that have clear benefit. It's probably why most of us just don't discuss PSA risks and benefits with patients in real detail. This study showed that only 10% of men who receive PSA testing reported having detailed shared decision making where more than one element was discussed. So maybe they were just presented one of the advantages or just presented a disadvantage, or maybe it was just mentioning of uncertainties, but they didn't really get the full picture like they should have. Here's another table of guidelines, this time looking at patients over the age of 70. Some of these guidelines, rather than listing a specific age, just say patients with a life expectancy of less than 10 to 15 years, but most of them just say 70 plus. And here you can see we're having a unanimous consensus that routine PSA screening for low-risk asymptomatic patients should not be done above the age of 70. There are no randomized control trials that show mortality benefit to PSA screening for ages 70 plus. The number of false positives, overdiagnosis, and harms also escalate with age. And the timeline to any possible benefit is likely longer than their estimated life expectancy. Since prostate cancer is most often a slow-growing cancer, something that would take 20 or 30 years to kill them when their life expectancy is significantly less than that is probably not worth chasing. Here's another table of guidelines, this time looking at ages 50 to 54. And again, we're back at kind of a 50-50 split between the maybe and no group. There are no entire studies showing mortality benefit outside the ages of 55 to 69. But if we look at the individual site from the Sweden arm of the ERSCP study, they did start at 50, and that one site on its own did have statistically significant results. So starting at 50 instead of 55 is not crazy. There's really no randomized control trial data supporting screening patients younger than 50. Another controversial topic is the frequency with which we do PSA screening. All of the guidelines, which list a particular frequency, list that PSA screening should be offered every 2 to 4 years. And this mimics the ERSCP study, where different arms of that study screened with frequencies between 2 and 4 years. While most of the sites did 4 years, the Swedish arm that had the more significant results did do it every 2 years. There are no guidelines that recommend routine annual PSA screening, even though most providers, that's what they do, unfortunately. There was an observational study comparing 2 to 4 year intervals, and they found similar rates of aggressive cancers in both groups, despite the every 2 year frequency having much higher rates of non-aggressive cancers. So again, here we see that the more you do PSA, the more cancers you'll find, and the more downstream effects those patients will probably have, but you're probably not having a meaningful impact on the patients because you're not finding many aggressive cancers if you check more frequently. With each successive round of PSA testing, the detection rates for prostate cancer and the positive predictive value of a PSA test decline. In the ERSPC, the cancer detection rates for PSA decreased from 5.1% in the first round of screening down to 4.4% in the second round. And the positive predictive value for a PSA above 3 decreased from 29 to 19%. And that's just the difference between the first and second PSA. If you project out and think about a guy who might be getting 15 or 20 PSAs, the value of that 15th or 20th PSA is just going to drop and drop and drop with every round. Some subpopulations where PSA may make more sense. Really anything that increases the pretest probability, in theory, decreases false positives and increases your positive predictive value. A family history can correlate with more prostate cancer risk, but the studies on this are in somewhat of a gray zone. It's unclear how much a family history of prostate cancer really increases that individual patient's risk. And the randomized control trials, while subgroup analyses have been done on the percentage of patients that had family history, the studies were underpowered to really show statistically significant differences. There's some observational studies that show that there may be increased PSA benefit in these patients, but it's, again, kind of murky. Guidelines specifically relating to patients with a family history, the United States Preventive Service Task Force says there's insufficient evidence to have a different guideline. The American Academy of Family Physicians and the American College of Physicians do not have separate guidelines based on family history. The American Urologic Association recommends starting shared decision-making at age 40 to 45 for patients with a family history. And the American Cancer Society recommends starting shared decision-making at age 45 for individuals with a primary relative with prostate cancer diagnosed before the age of 65. I think those two caveats are good things to have. Sometimes patients will tell me they have a family history, but what they're actually talking about is like their second cousin who shares very little genetic material with them. Or if the family member that had the prostate cancer was diagnosed at like 80, again, that doesn't really tell us much. Most 80-year-olds have prostate cancer, so I might disregard that as being a risk factor. Patients from African ancestry do have worse prostate cancer outcomes, with prostate cancer mortality being roughly twice as high in African Americans compared to Caucasians. But a lot of that difference could just be due to structural causes and differing access to medical care. There are a lot of conditions where, unfortunately, African Americans have worse outcomes than Caucasians, and usually that does not represent a genetic predisposition. It's more of systemic problems. Doing race-based screening also has ethical concerns, especially when the screenings have more harms than benefits, like the PSA does. Additionally, the one study, the ERSCP, that showed benefit to PSA screening included very few men of African ancestry. The United States Preventive Service Task Force has insufficient evidence to give a different PSA guideline for specific ethnicities, as well as the AAFP and the ACP. The AUA recommends doing shared decision making starting at age 40 to 45 for African Americans, and the American Cancer Society recommends doing shared decision making starting at age 45 for African Americans. Most prostate cancers are androgen sensitive, so using testosterone replacement therapy could theoretically accelerate pre-existing cancers. So some might assume that checking PSAs more aggressively in these patients makes sense. But this has at least partially been debunked. Meta-analyses have shown that while testosterone replacement therapy slightly increases the PSA initially, there's no real increase in prostate cancer, at least over a couple-year follow-up. Most guidelines do not have a specific guideline for this subpopulation, but the AUA and the American Endocrine Society do recommend checking a PSA prior to starting testosterone as a baseline, and then again 3 to 6 months after starting hormone replacement, and then just annually. But none of the guidelines recommend checking a PSA every 3 months, for example, and that's what I see a lot of providers doing, because they're checking the testosterone every 3 to 6 months, so they just add on a PSA with every test. So they're overdoing it by a factor of 2 to 4. I do want to clarify that everything I've been talking about today is for screening PSAs. If we're talking about patients who have symptoms of prostate cancer, or they had a prior abnormal PSA, or they've even gotten treatment for prior cancer, these are all patients in a different category. So they're high enough risk that PSA screening makes sense. And in that case, it would really be a diagnostic PSA or a surveillance PSA and not screening. When I'm talking about screening, I'm just talking about people who don't have particular symptoms or risk factors. Digital rectal exam, I'm just going to briefly touch on this because screening DRE has all the same drawbacks as PSA, except it's even worse. DRE only reliably detects large, advanced posterior prostate cancers. It's also unpleasant for patients and leads some of them to avoid seeing doctors. I've had a number of patients who see me for a new patient appointment and they haven't seen a doctor in 10 or 20 years, and I ask them why, and if they're honest, some of them will tell me that, like, hey, last time they did a rectal exam and that was not fun, so I decided to stop coming to the doctor. And as you would probably assume, not seeing a doctor for decades in this age group tends to lead to a lot of bigger problems than prostate cancer. DRE has not been evaluated in a randomized controlled trial on its own, but multiple studies which evaluate the addition of DRE to PSA have not had mortality benefit. The negative predictive value for DRE is even worse than PSA, and it's only 64%. The biggest drawback to DRE, it has poor reproducibility. The inter-observer agreement on digital rectal exam is very low. So even two experts, two urologists, will agree a relatively low percentage of the time. The way we evaluate the reproducibility in this type of setting is the kappa value, where a kappa value of 0 means the two urologists have totally random results that are not agreeing, and a score of 1.0 would be perfect agreement between the two urologists. And in this case, the kappa value is 0.22, meaning that the inter-observer agreement is only slightly better than chance. I will mention that one downside to us not doing regular screening digital rectal exams is that we are less skilled at detecting issues when we do a digital rectal exam. But when the digital rectal exam has limited accuracy to begin with and limited benefits, I don't know that us, at least in the primary care world, becoming less skilled at this is really a big drawback. The United States Preventive Service Task Force still gives screening DRE a category D, so it's actively discouraged. And there's a bunch of other guidelines too that actively discourage doing screening digital rectal exams. The most recent AUA guideline recommends against standalone screening DRE with a evidence rating of A. But they do also list DRE as an optional complement to PSA, which itself is an optional test after shared decision making. But the strength of evidence for this part is only C, and C in their ratings is the lowest rating. So it's basically just expert opinion. They don't really have any hard evidence to back up this recommendation. So now let's put it all together and review the spectrum of options, because there's not one clear yes or no, right or wrong answer with this. There's more of a gray zone. So we'll start over here on the left in the green area with the things that are best supported by the evidence. And then we'll get into kind of a gray zone where it's reasonable to do these things. And then as we get over to the right, we'll see the things that are really not reasonable to do. So over here in the green, the best supported evidence would be doing true shared decision making for biannual PSA screening for men between the ages of 55 and 69. But I will add the caveat that I would only recommend doing this if you have time after addressing all other clinical topics with more clear benefit. If the patient's systolic blood pressure is 160, or their A1C is 10, or they haven't had colon cancer screening, you're really wasting your time to do a 10-minute discussion on PSA, because that's much lower stakes. So all those other things higher on the to-do list really need to be addressed first before you dive into this, in my opinion. Another option that is well supported by the evidence is only providing shared decision making for low risk screening PSA if the patient introduces the topic. So you may not even offer it, and you might only do the shared decision making if the patient brings it up. If you're curious, this is mostly the camp that I'm in. So I will screen patients for a family history of prostate cancer. I will screen patients for symptoms of prostate cancer. But if after that they appear to be low risk, the word PSA doesn't come out of my mouth. Now they may still bring it up, and then in that case I'll dive into my spiel with them about the risks and benefits of PSA. but I won't initiate the topic unless they do in some cases. Now we'll get into kind of the gray zone where it's reasonable to do these things, but there's not good, hard evidence to support it. So more strongly encouraging PSA or considering starting at an earlier age based on family history of prostate cancer. If you're curious, I do this. So I do try to more strongly nudge patients to get a PSA if they have a strong family history of it, a primary relative at least. Another reasonable option is to do the same thing in people of African ancestry. I personally do not do this because I think the evidence is even more unclear with this situation. Doing annual PSA screening in men on long-term testosterone replacement is also reasonable. And starting shared decision making at age 50 instead of 55 is also a reasonable option. Now we'll get into the unreasonable options, and unfortunately there are a lot of things on this list that many providers are doing. I'm all for provider and patient autonomy, but if we're going to be an evidence-based profession, at a certain point we just have to draw the line and say some things are just wrong. So ordering screening PSAs without discussing the risks, uncertainties, and limited benefits with patients is not reasonable. Doing annual PSAs as a routine practice is not reasonable based on the evidence. Routinely screening patients above the age of 70 is not reasonable based on the evidence and the guidelines. Checking a PSA every 3 months for patients on long-term testosterone replacement would not comply with the guidelines. Doing any screening asymptomatic digital rectal exams. And on the other end of the spectrum, just refusing to do PSAs, even if the patient is well informed and requests it, I think that would be unreasonable too. So how are we doing as a profession compared to these guidelines? Of men who have had a PSA, 64% of them have had it within the last year, which would suggest most doctors are just ordering PSAs every year instead of every 2 to 4 years. So that's not so great. The rates of PSA screening, even for men in their 70s, is more than half, even though there's a consensus among the guidelines that we should not be doing that. It's even 40% in men in their 80s. When the specific reasoning behind a PSA was looked at in a study, 70% of the PSAs were ordered as just part of a routine thing rather than having a specific indication or patient preference. I already touched on this before, but only 10% of men who get a PSA test have true shared decision making with their provider. And 8.9% of outpatient visits in 2020 for men between the ages of 45 and 75 had a digital rectal exam documented, which was pretty surprising to me. Now, some of these visits might be oncology or urology visits, which make more sense if the patient has symptoms or condition. But still, almost 1 in 10 visits for men requiring a rectal exam is something that could clearly dissuade them from coming in. When I've given this lecture before, a lot of the comments kind of fit a narrative where people will say it's hard to argue with the numbers, it's hard to argue with those guidelines, but, and then they kind of give me a story about a specific case. They might say something like, my uncle was in his 80s, didn't get PSAs, and he ended up dying from prostate cancer. Or they might say, I had a patient who got a PSA in their 40s, and I think it saved their life. So I have 2 different responses to this. One is more emotional, one is more logical. So the emotional part is that prostate cancer is common, and it can be awful. So unfortunately, a lot of us have been personally affected by it. We've either lost patients or maybe even had friends or family members affected by prostate cancer. So it's a scary thing. That might push some of us to feel like we have to do something, even if the options for things we can do don't have a clear benefit. This may be a scenario where the often quoted phrase, "don't just do something, stand there," would apply. And on the other hand, the more logical response to these two anecdotes would be, one, that the gentleman who died in his 80s from prostate cancer, there's no guarantee that the PSA would have detected it, since PSA misses most cancers. And there's no guarantee that diagnosing the cancer slightly earlier with the PSA would have changed the outcomes. That's not a given either. And for the gentlemen in their 40s, that they think that PSA saved their life, that may not necessarily be true either. There's a 50% chance that cancer that was identified in the gentleman was just overdiagnosis. It may have never caused any issues. And even if we were diagnosing something that was going to cause issues later, it's unclear if diagnosing and treating that cancer earlier really affects the outcomes. Most prostate cancers are slow growing, so PSAs might help you identify it a few years earlier before there are symptoms, but it's unclear if that really changes the overall outcomes for the patients. Especially when we're evaluating screening tests that we're going to give to a broad portion of the population, we really need to look at the hard data with randomized control trials rather than just retrospectively picking out individual anecdotes and using that to justify how we're testing or treating people. Even if you feel like you know an 80-year-old patient that was truly helped by PSA, the data shows that at best, this is so rare that the large studies we have really can't detect it. So this is not happening frequently enough to really move the dial. I'll leave you with a couple quotes from Dr. Richard Ablin. He is the doctor who discovered PSA in 1970. He has described widespread PSA screening as a public health disaster. He says PSA is prostate specific, not cancer specific. It is present in the normal, the benign, and the malignant prostate, and testing should absolutely not be deployed to screen. I've got my citations here, which I'll slowly click through in case you want to pause and take a look at those. And then the take-home points are that it's clear that prostate cancer screening has no all-cause mortality benefits. Low-risk asymptomatic screening PSA has somewhere between 0 and very low absolute prostate-specific mortality and metastatic benefit. Even if we cherry-pick the most favorable data for PSA, dozens of men will have permanent harms, including erectile dysfunction and incontinence, for every one man that benefits. PSA screening leads to overdiagnosis of cancers that would have never presented clinically. Many of us are doing some combination of annual PSA testing, testing without true shared decision making, and testing after age 70, even though there's a consensus among medical guidelines that those activities should be discouraged. And just generally don't do screening digital rectal exams. Thank you for watching.